So one of the last slides, I just want to talk about some of the experimental or emerging therapies. So when we see patients with asthma that are poorly controlled and the other medicines aren't working, we start to think of some emerging therapies. And so I just wanted to bring up some of these just to visit about them. So anticholinergics. So anticholinergics are used all the time in patients with COPD. And long-acting anticholinergics are starting to be revisited for asthma. So there was a really interesting New England Journal of Medicine article last year that looked at adding on tiotropium for those patients with moderate to severe persistent asthma that were not well controlled on their asthma therapy. At least in this group, those patients were on inhaled steroid, and they randomized to 3 groups. They added on tiotropium, they doubled the dose of the inhaled steroid, and they added on a LABA in the form of salmeterol. And in those patients, when looking at the addition of the anticholinergic, that improved morning peak expiratory flow, improved lung function compared to doubling the dose of the inhaled steroid, and it was non-inferior to the salmeterol. So the study was really short, and that's one of the biggest limiting factors. So there's not enough data to really go off of what to do for long-term. But like LABAs, if we use anticholinergics without an inhaled steroid, it could mask inflammation and get us into trouble like what was seen in patients that were just on LABAs by itself. Macrolides, there's been conflicting data about the use of macrolides in asthma, but in some patients, a trial of 6 weeks of clarithromycin may be something you'd want to consider. TNF inhibitors, the studies have been very disappointing. And then anti-cytokine therapies, there's a lot of emerging evidence for this. And this is really in the future to really understand this better. And then one of the last points is that, again, there was this really interesting article looking at anti-IL-13. And IL-13 is involved with the allergic cascade. And they took patients with poorly controlled asthma and gave them anti-IL-13. And they noticed that those patients that had the greatest improvement had high serum periostin levels. And periostin is basically just a marker of allergic inflammation or IL-13 activity. So this sort of goes back to the whole endotyping asthma. So if we can endotype a group of patients that have this specific IL-13 driven predominant asthma, perhaps therapies like this can treat it better, improved outcomes with less side effects.